Okay, so hello everyone and welcome back. I'm David Longman from Australia. I'm a TANGO2 dad as well as a board member of the TANGO2 Research Foundation and Research Committee. I'm honoured to introduce our next presenter, Dr. Georgia Sarquella Brigada. Dr. Brigada, a TANGO2 Research Foundation Cycle 5 awardee, is the head of arrhythmia, inherited cardiac diseases and sudden death unit at the Hospital Sant Joan de Déu in Spain. She is also a professor of medicine at the University of Barcelona and University of Girona, in addition to the Director of Research in Arrhythmias and Inherited Cardiac Diseases at the Institute d'Arasaka Sant Joan de Déu. Welcome, Dr. Sarquella Brigada.
Thank you. Thank you very much. And thanks for letting me be part of this. And of course, the TANGO2 Research Foundation for awarding us for this nice research that I think it can bright up a lot of good things. I see that you are putting the slides, so shall I then move them by myself, or you are doing that for me?
Yeah, you should have an invitation to take control of the slide deck. Just click on that and you should be able to run it.
Okay. Yeah. Okay, just I click here and that's it. Okay, great. Thank you so much. So, well, as a pediatric cardiologist, I'm going to be exploring the heart, of course, and mainly one of the parts that I think it's very interesting is how we monitor those patients. Our story with TANGO2 patients started the other way around. We were worried about certain patients that we were finding them to have arrhythmias, and we were not really sure what was the reason. And we did all the rhythm analysis and of course explorations without really knowing why. It was certain years after that those patients turned out to have TANGO2 disease, or we described that they had TANGO2 disease. So we have gone through certain, well, I would say protocols that helped us know a little bit more about those patients, which will put a little bit of light in certain situations, and especially before the treatment with vitamins was described and studied. So I think we have gone through the natural history, cardiac natural history for those patients, even before we knew that they were TANGO. So what we wanted to do with what the research we have been awarded, it's just to put all this information together. And not only that, but for those patients that we keep monitoring, just to take the most of it and try to understand better what is going on with them. So, and to do that, and I know that our audience is very varied, so it's important just to make sure that we all understand what we are talking about. So my idea, I should have control, but I don't have control. So, okay. Just to share with you that what we do in our arrhythmia department is that we deal with arrhythmias, we deal with genetic cardiology, with sudden death and everything related to sudden arrhythmic death syndromes. And one important part is the remote monitoring, cardiac remote monitoring for those patients. And one important part, for example, of sudden death is that sudden death at the end is a symptom or a sign, but in fact, there are many things behind that. And that's what it's all about. And we need to rule out which are those shadows that appear in those apparently healthy hearts, that we really need to know what's wrong with them or what might be wrong with them, just to be prepared or to put treatments or to try to avoid certain complications for those patients. So with TANGO2 patients, and I think this is very important to understand, and this is a slide that even though I know that you know it very well, this is something it's important to know, that those diseases are very rare because they are recessive, and they are difficult to diagnose because at the beginning they might be very, I mean, people can get into confusion, and that's important. And what do they have in common is, for those patients who are not aware of that, is that they get very sick when in certain situations. But for those, from the cardiology point of view, those situations, we are actually, we are called because there is a patient doing arrhythmias and nobody knows what to do. And even us, we don't know what to do. That's why we get so worried. And that was what really happened with the first patients we met. I was a resident, a third-year pediatric resident, when I had a patient under my supervision, and she got in this terrible electrical storm, terrible arrhythmias, uncontrollable arrhythmias, and we could do nothing. 10 years later, being already a consultant in the same hospital, the sister appeared with exactly the same situation. And TANGO2 was not even described. And it was so frustrating for us, the fact of having those two girls, two sisters with the same situation and with the same end, and without being able to help them. So what we saw as cardiologists, it was a big question tag there. And that's why it was, I think, that helped us to understand and to just try to understand what was going on, and to rule out everything. So every time we had a patient that presented with similar situations, we were doing a very deep cardiac study on them, without really not knowing what we were looking for. So now we know that those metabolic crises can raise into cardiac crisis. And during cardiac crisis, there is a very severe electrical instability. We can see prolongation of the QT interval. We will talk about that. Ventricular tachycardia, ventricular fibrillation. And this is a very dangerous situation. And we know that between crises, what we learn, before knowing there were TANGO2 patients, what we learned is that between crises, the heart was structurally normal, but now we were wondering, is that always true, that those hearts were structurally normal and electrically normal all the time? So we learned that, of course, fasting was a bad situation for them, and of course fever also. But there are many other arrhythmogenic syndromes not related to TANGO that are very sensitive to fever and dehydration. So we start kind of thinking what we were doing wrong, why we were not able to diagnose those patients of those known diseases. So this made us prepare many new protocols in order to understand better what was going on. We knew that, of course, viral infections, even emotional stress, even heat, very common situations for other arrhythmogenic diseases. But what it was different was for certain patients, hypothyroidism, which is frequently a trigger for TANGO, was also there in our patients, but that was not common in another arrhythmogenic syndromes. So that made a big difference, that we even realized that that situation was there. Sorry, because this goes slower than I would like to. So what we learned is that normal ECG and echocardiogram were seen in those patients, but during crisis, we could see prolongation of the QT interval. We could see premature ventricular contraction, so extra beats coming before it was expected, polymorphic ventricular tachycardia, ventricular fibrillation, like unresponsive to all treatments. Even we saw a transient Brugada type 1 pattern, which I will explain now better what it is. And specifically, Brugada syndrome is one of the diseases very sensitive to temperature. So that was really common with those patients. And sometimes we could see that there was a little bit of dysfunction of the cardiac pump. So what we call systolic and dysfunction and cardiomyopathy. And of course, the heart was structurally normal. All this was recovered between the crises. But when we see that we saw prolongation of the QT, what is it exactly? And I think this is important. But this is a normal ECG. What we see is that those are the atrium beats coming from we call P wave coming from the atrium, the QRS coming from the ventricle, and the T wave, which is the recovery and the recovery to the basal status to be prepared for the next beat. That's the normal ECG. What we see in those patients is that this P wave is normal, QRS is normal, but we see a very prolonged, a prolongation of the QT interval, the starting of these big waves here until the end of this wave. And there is a prolongation on that. And this is very typical on what we see on those patients. And why does it happen? Well, we know that QT interval is regulated with many ion channels that belong to the heart, and it can prolong for different situations. We see that when there is a loss of potassium channel function, we see the prolongation of this QT interval. And also when we see a gain of function in sodium channel, we also see a prolongation of this interval. So both situations, loss of function of potassium, gain of function of sodium, show us a prolongation of the QT interval on the surface ECG. And why this is important and why this is dangerous? Well, because this confers a specific instability, electrical instability, and those patients end up having very severe ventricular arrhythmias, and what we call it torsade de pointes and even ventricular fibrillation. And this is bad because the pumping is not working. And what is a Brugada pattern? Well, we go back again with the ECG that we already know, and we see that this part here, these are the precordial leads, the leads we put just in front of the chest, in the middle of the chest, that we see that these things needs to be flat between every one of the waves. And what we see, there is an elevation of the mid segment, what we call the ST segment. There is an elevation of the ST segment, certainly in those precordial leads, on those leads just that are positioned in the middle of the chest. And why is this dangerous? Well, for the exact same reason, because they end up having those arrhythmias. So we said, okay, we find out these patients had those arrhythmias. How can we monitor them all the time? And that I think that we had the help of something that came into the market, which was a miniaturized device that was very small compared to what we had before. What we called implanted loop recorder or a subcutaneous holter. That small device can just register the rhythm of those patients for a long time. And we can have them stored in the same device, and we can interrogate it, and we can know whether there are asymptomatic arrhythmias or there are some things, or sometimes the patient presents with a symptom and we can just see if there is something wrong in the rhythm of the heart. And that's what we got here. Actually, by studying those patients and using remote monitoring, which is a way that we can recruit all the electrical information and end up in even the subcutaneous holder in a platform that we can get all that information from our patients. We can register that and learn from that. And that's what we do on our, what we call Cortex Clinical Command Center of our hospital, which we kind of put together all the electrical information and symptoms and clinical information, genetic information of our patients, wherever they are in the world, no matter where. So now medicine, it's border-free. We can just get that information whenever the patient is, and we can study those patients wherever they are to get the most of it, to get the most of that information. And what we are seeing in those patients, what we could see in those patients, actually, this is the normal rhythm of the heart. So everything starts here. This is the sinus node, and the sinus node sends the electricity down into the AV node, and then the electricity spreads in the ventricle in a symmetrical way. This is the normal rhythm. And what we could see is that those beats, we could find that at certain points that they were a little bit slower, and we could see kind of small pauses or a slow rhythm at certain times. Not, this was 7:30 in the afternoon, so it was not a sleeping time. For that, the patient was asymptomatic. He could not feel that. We could see some periods that they might be longer of small bradycardias, and also certain moments that there was what we called a more severe bradycardia. This is a very prolonged rhythm disturbance, and what we called a systole, and also what we could see in those patients that some of them could be asymptomatic or having mild symptoms there. So we didn't really know what we should do on those patients. Of course, now we have done something to change the natural history. We are giving them the vitamins, and that's the role of the vitamins that have changed our patients. So for those patients that we had them monitored before knowing that they were TANGO, now we keep monitoring them to see if by giving those vitamins, we are changing that, and we stopped seeing those types of disturbances. And of course, just getting the most of it, the most information possible for those patients to learn more about the disease and to learn more about which is the role of those vitamin Bs. And of course, to see that if in between crises, we can do better. And there's nothing wrong in those, to make sure that there's nothing wrong in those hearts between crises. Therefore, avoiding crisis, avoiding fasting, dehydration, and treating infections with really, and of course taking vitamins, will really diminish the number of crises and arrhythmic disorders. So I think this is what's next. Well, we will follow up all these monitored patients. We will extract the information. We will try to see which is the impact of the B vitamins to improve those patients, and to know which is the role also in those asymptomatic little findings that we find, and if they have a role on there as well. So I have the privilege to be surrounded by a fantastic team here at Sant Joan de Déu, and of course working for our kids, trying to get the most of each one of them, and trying to improve what we know and we will still need to know. Thank you very much.
It's a really interesting setup and like really powerful setup that you have there. And I want to thank you for all the work you're doing. And I would really love to open it up to any questions from the audience. I don't know if this is from Bob Mitchell. I don't know if this is necessarily one to add on to your question. But from my standpoint, do you have any preliminary data from the rhythm monitoring that you do outside of cardiac crises to say if there's any periods of time where we see where you've seen abnormalities in your
Well, yes, those patients that I just showed, they are inter-crisis. They were not in crisis when we got those information. I have to say that was before starting vitamins.
Got it.
Yes. And there is this interesting question that did they stop doing pauses? I have to say that we haven't seen other pauses now, but the number of pauses before were small. So say that now we have 0. It's very, I think it's too much, because if we have had 1 every day and now we have none, of course this is a big difference. And I think we need to do a prolonged follow-up to make sure that we have enough evidence to see, okay, they really stopped doing pauses because of the vitamins. I have to say that we are okay, we are very optimistic, but we need time to make sure that we are exploring all that in a very, I think, a very clear manner to make sure that whatever conclusion we get, it's supported by time and evidence.